Hey, good morning, everyone, and welcome to Euronurse. I'm your host, Vic Sinise. Glad to see you on board. Hey, you probably noticed the background's a little different here. I'm doing a remote. This is coming to you from Charleston, South Carolina. Probably can't see out the back, but that's facing towards the ocean. A little creek behind us, not right on the ocean. But anyway, it's a neat place. Hey, if you're watching us live, welcome to the show. We come to you every Saturday at 9 a.m. Central Time. Of course, I'm at 10 a.m. now because I'm in the different zone, so it's throwing me off. But be sure to hit the subscribe button and welcome to the show. If this is your first time checking us out, be sure to go to our website at euronurse.com and let us know how you like the show. You can put comments and questions through there. You also the best place to go to find all of our past episodes. So check that out to check out any of our past episodes. If you want to listen to us in your car, no problem. You can check us out on our Euronurse Plus area. The Plus area is where we go to put up all of our episodes in an audio version, and you just check those out. So go ahead and look at our Euronurse Plus area for those shows. This is where I normally would bring in the experts to meet with everybody, but guess what? I'm the only expert. So I'm going to ask our at-home crew that are watching it live that if you have any issues or problems with the show, let me know in the comments section. I'll be monitoring that. Like if suddenly you can't hear me, because again, my experts have all had issues with getting on the show not because of the remote, fortunately, but Andrea, I think, just flew back home from Paris, and John Lynn's at the AUA, and I know Lori had something going on at home. So you got to deal with just me. Now, it does give us a unique situation in that if anybody in the audience wants to join the show, they have a camera and a mic, and later on during Q&A want to come on live, just put that in the comments section. Supposedly I can do that. I haven't tried it before, but this will be the day we can try it. Otherwise, no problemo. I'll be glad to handle the questions just myself. You'll get my opinion, but I'm the speaker for the show, so I guess maybe my opinion is one that matters. So great. Since I won't be doing much more introduction than my own, for those of you that may be new to the show, I am a registered nurse, have been involved in urology for the past 40 years. And this was my way of paying it forward. And it's been really kind of a fun adventure to be able to see everybody and talk to everybody every week. And the show is doing great. So I'm going to go and switch us over to the actual show. Now, I did pre-record this because I was worried that I might not be able to get things to work here online. So I'm going to be playing the pre-recorded part of it. So you'll notice the backdrop will change, but I'll be coming back on live. So here we go. All right. Well, let's get into our talk here. So we're going to talk about Botox for overactive bladder. I got some tips and tricks for you. So let's talk about, first of all, why we do this. What are the symptoms that we see with overactive bladder? Well, as you see this guy here, you run into the bathroom, urgency, frequency, getting up at times the urge is so strong you don't even make it without wetting yourself a little bit. So urgent incontinence. Any of those would qualify as overactive bladder. I think it's important to look at the pathophysiology of voiding, know a little bit about how the system works. And when the bladder is full, it sends a signal. The signal goes to the brainstem. The brainstem then sends its signal back down the sacral spinal cord, which innervates the bladder and the urethra. So the bladder muscles contract, the urethra relaxes, allowing urination. Pretty simplistic model. And really, this is kind of what mimics what we see going on in a baby's bladder, not so much what we see in an adult bladder, because we're able to inhibit our urination when we start getting those signals coming up from the bladder. So thanks to work from people like Dr. Fowler, we have this model where the cerebral cortex can also override the brainstem and voluntarily control urinations. This is what allows us to hold our urine until we find a convenient place to urinate. So the signal is sent up, and it's coordinated between this periaqueductal gray area and the premotor cortex. Boy, these are mouthfuls. So we call them PMCs and PAGs. So the PAG sends a signal to the PMC, which starts to let it know sensory wise, we start to get a sensation, hey, I got to go to the bathroom. My bladder's starting to fill up. But we inhibit that. We're able to stop that signal so it doesn't go right back down the brainstem and fire off the bladder until we get to a bathroom. Then we can go ahead and send that signal down and we get a normal urination. So pretty neat way it works that they were able to figure this out. I do a lot of urodynamic studies, and nothing demonstrates OAB like a urodynamics. You start filling the bladder and you can see it almost instantly. And here's what this looks like. So you've got a sensor in the bladder, a sensor in the rectum. The rectal sensor is to determine whether somebody's moving or coughing or things that could cause artificial, what we call artifacts, versus the bladder actually firing off. And then this one here is the machine doing the math between these two numbers here. So when we see this go up, we know that's really the bladder firing off. That's the bladder firing off. Now, this is during filling, not when we told them to try to void. So we should see that when you're voluntarily voiding. But this will be OAB, classic OAB. And in this one here, as I kind of put a little arrow there, we actually see that this last sensor shows any urination. So this patient did leak some urine while the contraction was occurring. So we know not only do they have overactive bladder, but they have overactive bladder with incontinence. So urodynamics is a nice way of evaluating overactive bladder. So let's talk a little bit about Botox. Botox was first approved in the US by the FDA in the late 80s, and it was approved initially for eye orders such as eye muscle problems like crossed eyes or uncontrollable blinking, or things like crazy things like that. It wasn't until 2002 that it got the approval for cosmetic use, specifically kind of getting rid of these frown lines between your eyebrows. And of course, now they inject any little wrinkle on your face to help relax that and improve your appearance. So I hear. Botox works by temporarily blocking the release of acetylcholine, a neurotransmitter that signals muscle contraction. By doing so, it causes a temporary muscle relaxation, which is what we want. So if you have an overactive bladder and you start injecting this Botox in there, you'll relax part of the bladder and kind of break up those signals and get a more normal bladder capacity and holding. Now, it's not considered first-line therapy, and in order to go on to have Botox, you typically have to fail first-line therapy. So what is our first-line therapy? Well, that's typically our oral medications. So oral medications are successful and can be used to reduce the symptoms of overactive bladder. It's our go-to drug. No pun intended, or maybe pun intended. There's two types of drugs that we typically give for the bladder. One are anticholinergic medications, such as oxybutynin, tolterodine. And the other is more new, called the beta-3 adrenergic agonist. So one is a blocker, the other one is a relaxer. So you can block the acetylcholine reaction by the bladder, so kind of like the Botox does, or you can relax the bladder, kind of like I say like a muscle relaxant. So it works specifically on the bladder. The beta-3s tend to be more targeted than the alphas because there's the anticholinergics. There's anticholinergic receptors all over our body, and that's where we get into some of those side effects with those medications, because you've got those anticholinergic effects in your mouth, your eyes, so you can get dry eyes, dry mouth, constipation. So those are the things that can happen with that. Behavioral therapy is another option that we can go to, and that's the Kegel exercises. So we haven't talked about that, but that is considered first-line therapy. Teach somebody how to do Kegels. You can actually get good effect if you do them, but you got to keep doing them. That's the problem. So with the medication side effects, and people drop out and get tired of taking the drugs. With the behavioral stuff, people get tired of exercising and doing it because it may work, but once you stop, it may not keep working. So what do we do to select our patients? Well, medical history, physical exam. We talked a little bit about that. Urodynamic test can help in evaluating this, and some shared decision making makes a lot of sense. If the patient buys into the treatment, it's a lot better that they're involved in the decision of what they're going to try and how we're going to go about this. So some patient advocacy here. Most insurances only require failing one OAB drug, so that's enough to go on to second line therapy and try something like Botox. And we do know that failure rates are pretty high with the drugs based on side effects, as we talked about. And, you know, sometimes just people getting tired of taking medications and stop them. So all sorts of reasons that we fail them. You know, sometimes it can be cost. Some of these medicines are more costly, like the betas are less coverage on, you know, for Medicare patients. We also worry about things like the anticholinergics can be increased risk of dementia in our elderly. So there are some good reasons that we might not want to put them on that. So let's talk about how we do this, the procedure. Now, what I put together is what I call my Botox checklist. And I have all of our employees that are assisting with Botox go ahead and run through this whole checklist with people. The big thing is that you want to make sure that, number one, they're not taking any blood thinners. Really important, because you're going to be sticking needles all over the bladder. And if it starts to bleed, you're not going to be able to see from the first needle stick to the last needle stick very well. So you won't be able to get good placements if you can't see, because you got this cloud of blood in the urine. If you ever looked through a cystoscope when somebody's got blood in the urine, it's like a cloud you're looking through. So like almost like smoke. So you want to make sure they're off their blood thinners. So they aren't, it's a dead stop. The second thing is urinary tract infection. You want to make sure you check their urine, make sure there's no urinary tract infection, because that also puts them at risk for sepsis. You know, you're sticking needles in, and if you try to go through a contaminated urine, you could push that bacteria into the bladder wall. So that's another stop. Any of those, it's canceled. Come and reschedule it. But let's assume that they've stopped their blood thinners, their urine's clear. So we're going to go on and do the procedure. Here's the way I recommend that we do it. We've gotten through our two first big stops. Now you can go ahead and place a Foley. I like using a Foley. You can use an intermittent catheter, because you're going to instill lidocaine in the bladder. That's really the only and the best anesthetic necessary for this. The lidocaine does a great job of numbing up the bladder. So you put I say 20 mLs, anywhere from 20 to 60 is what I've read, of 1% lidocaine, and reconstitute your Botox once you've put the lidocaine in the bladder, because it should sit in there about 20 minutes. And this gives you plenty of time to reconstitute your Botox, get all your equipment assembled. Then you drain the bladder. You're going to flush the bladder to get the lidocaine out with another 30 cc's of sterile saline, and then remove the Foley, and the patient's ready for the doc to come in. Again, drop your lidocaine in advance. I said anywhere between 20 to 60 cc's. You know, sometimes if patients have a lot of contractions, it can be a little bit tough to get them to hold 60 cc's. But anyway, see whatever your particular doctor's liking is, that's what you go with. Again, it should stay in the bladder for about 20 minutes to really get a good relaxation or numbing effect to the bladder. As I said, you have to assemble the equipment that you need. The equipment that you need for this, we use ours. We use a video scope for this. It's because we're doing it with the doc. We're assisting, so both people really it's helpful if they can both see. Otherwise, one person's working blind. This is the rigid scope that we use. We don't use it very much. We started out with it, but we don't use it very much anymore. But I thought I'd include it because some people might. This is kind of a handy injector type thing. You put the needle through there. You can see this thing right here the needle goes right through the scope, and this little hand grip allows them to push the needle in and out of the bladder that way. Again, we do flexible scope for all these now. The needles that we use is this Injected, and then this Coloplast bony needle. Either one of those are fine. What it has is this little adjustment right here where you can click the needle all the way out, so it's not protruding at all, to different measurements on here as to how far the needle sticks out beyond the end of this thing here. So there you can kind of see what it looks like all assembled and ready to go. And this is what that needle looks like when it's retracted, and this is when it's extended. So typically once they're in the bladder and they're ready to go, we go ahead and extend it to whatever level they want it. Ours is always uses it all the way. So how do you mix Botox? Well, I got a video. This came from their website, the company that makes Botox. So I borrowed their video, but I did chop it down a little bit so it's a little less boring. But anyway, here it goes.
Botulinum toxin A only. Botox is the only neurotoxin with FDA-approved urologic indications. To determine whether you're using Botox, look for the holographic film on the vial label that contains the name Allergan within horizontal rainbow colored lines. Note that the Botox vial may appear to be empty prior to reconstitution because it contains a small amount of crystals. Do not reconstitute Botox until ready for use. Prepare Botox using aseptic technique. Wipe the top of the vials with an alcohol swab. Draw 10 ml of 0.9% non-preserved saline solution into the syringe and inject into the 100-unit Botox vial. It is important to remember that the vial is prepared with a vacuum inside, and the vacuum should automatically draw the saline into the vial. If for some reason there's no vacuum, do not use the vial. Contact Allergan customer service at 1-800-433-8871. Mix gently by swirling the Botox. Do not shake. You may need to vent the Botox vial to more easily withdraw the reconstituted Botox. Draw 10 ml from the 100-unit Botox vial of reconstituted Botox into the 10 ml syringe. Draw an additional 1 ml of saline into a separate syringe for final injection flush. Following the recommended reconstitution protocol will result in one 10 ml syringe with a total of 100 units of reconstituted Botox in a volume of 10 ml. This will give a dose of 5 units per 0.5 ml of injection. There will also be a 1 ml syringe of saline for the final injection so that the remaining Botox in the needle is delivered into the bladder.
So there you have it. So now let's talk about the actual administration of the medication. Again, we're using their video, but I think they did a nice job. So why recreate the wheel?
Single Botox treatment can be delivered with rigid or flexible cystoscope and consists of 20 intradetrusor injections of 0.5 ml each. Using this protocol as described will result in an injection dose of a total of 100 units of reconstituted Botox. The technique that will be demonstrated reflects the evidence-based approach from the pivotal trials. In this module, we will demonstrate the use of a flexible cystoscope. This is an example of the typical equipment setup required for the procedure using the flexible cystoscope. You will need a flexible cystoscope with a working channel, light cord, and light source. When using a flexible scope, you may also need a water stopcock to prevent leakage of saline from the working channel. Local anesthetic jelly is often applied to the urethra before insertion of the catheter. 1 to 2% lidocaine is instilled using a straight catheter with a catheter tip syringe. Typically, the appropriate volume ranges from approximately 40 to 60 ml. The instilled lidocaine should be left in the bladder for at least 20 minutes before starting the Botox injection. The bladder is then drained of lidocaine, flush with saline, and drain again to empty any remaining lidocaine or urine. Now, instill the bladder with enough saline to visualize the bladder wall, avoiding overdistension. If the bladder is overdistended, it can be difficult to visualize the infiltration. The proper amount of saline varies by patient. Typically, the appropriate amount of saline ranges from approximately 75 to 200 ml. You should fill the bladder enough so the bladder walls won't collapse in with folds, but not full where the patient is distended and uncomfortable. Load the needle through the back of the cystoscope into the injection port. For flexible scopes, be sure to take precautions when loading the needle so you do not damage your lens or working channel. Ensure that the needle tip is fully retracted prior to inserting down the working channel. When using a flexible scope, it can be helpful having an assistant depressing the syringe upon your order while you are working with the cystoscope and needle. Attach the syringe of the reconstituted Botox to the injection needle. Be sure to prime the needle to remove the air bubbles. Needle tip lengths can range from 2 to 8 mm. However, a 2 to 4 mm tip is usually preferred. Under direct cystoscopic visualization, insert the needle approximately 2 millimeters into the detrusor after penetrating the submucosa. When injecting the needle, you should see a subtle rise in the bladder epithelium. If the injection is too shallow, a blistering effect of the urothelium may occur. Under direct visualization, distribute the injections evenly across the posterior and lateral bladder walls, avoiding the trigone.
So I sped it up a little bit, but you can see where this is helpful to having video if you're assisting, so you can actually see when the needle gets touched and buried into the bladder wall. That's when you inject that half cc. So really quick procedure. Not as quick as it is when you put it in high speed, but it's definitely a quick procedure.
For final injection site, flush approximately 1 ml of normal saline from the 1 ml syringe through the injection needle to deliver the small amount of Botox remaining in the needle. This will ensure that the entire
So that's your
volume of
last
Botox
injection.
is delivered
So
to
you're
the
giving
patient.
that little bit of Botox at the end.
The saline inside the bladder used for visualization should be drained. The patient should be observed for 30 minutes post-injection. Monitor vital signs and ensure the patient voids prior to discharge from the facility. Upon discharge, instruct your patient to continue to take the prophylactic antibiotics for 1 to 3 days post-treatment and to contact your office if difficulty in voiding occurs.
So that's kind of the nice thing about using the flexible scope is you've somewhat filled their bladder, so you give them the opportunity to try to urinate right away, so they don't have to sit around as long waiting for their bladder to fill up. So this is just, again, a little review of the injection protocol that we were using that was shown in that video. This is a revamp of how you mix the Botox for the 100 unit. There's a little different mixing instruction for the 200. Again, whichever one you're using, just kind of read the instructions and follow what they say. There have been some custom mixing that some docs will do for this that we've done sometimes. Whatever works best is, what you want to follow. So safety, one of the common side effects of this, so safety and adverse events, the common side effects, of course, we're sticking Botox in the bladder. It's urinary retention. It could work too well. Fortunately, worst case scenarios, if they go into retention, is they just have to do self-catheterization. So all patients should be instructed that there's a risk of that, because sometimes it'll be temporarily, for the first few weeks, and then it goes away. Sometimes it can last till the medicine wears off. It's been pretty rare in our facility, but it can happen. Urinary tract infections, you're instrumenting a patient, that's always a risk. And then we're sticking them 20 times with a needle. So a little blood in the urine, let them know that's common. If it was more severe, it could actually cause, clot retention, etc. But if you follow all your requests, all your if you're checking everything ahead of time, make sure they're not on blood thinners, the risk of having any heavy bleeding is pretty rare. The other thing is, although less common, they are more dangerous. There are some symptoms you want to make sure the patient's aware of. So because the Botox can sometimes travel and affect other areas, always give them this information. We have a sheet that we hand out like this one here. If they have right away, let us know if they have problems with swallowing, speaking, breathing due to weakness of associated muscles, can be severe and result in loss of life. You're at the highest risk of these problems. You are at the highest risk if these problems are pre-existing before the injection. Swallowing problems can last for several hours. So that's one of the things, again, don't see it very often, but you want to warn them. Spread of the toxin effects. The effect of botulism toxin may affect areas away from the injection site and cause serious symptoms, including loss of strength and overall muscle weakness, double vision, blurred visions, drooping eyelids, hoarseness, or change or loss of voice, trouble saying words clearly, loss of bladder control, trouble breathing, trouble swallowing. If it happens, do not drive a car, do not operate machinery, or do not do any other dangerous activities. probably just get yourself to the hospital. Um, do not risk, due to the risk of urinary retention, only patients who are able and willing to catheterize themselves should be treated with this. So that's a biggie. You want to talk to patients about that risk because that one's more common. So efficacy and outcomes, how well does Botox work? It's really pretty impressive. I mean, this is, patients who have failed other forms of treatment really can get a great result. Nice thing about it is sometimes this is really, really long lasting. Patients can get by with as few as 2 treatments a year. I've had a few patients that have gone even almost up to a year with 1 treatment. So it's pretty impressive. The minimum, just so you know, if a patient says that, hey, it didn't work, I want to come back in, or it stopped working sooner than 6 months, it can be done every 12 weeks. So that's the very minimum in between that you have to have. So in conclusion, Botox for overactive bladder is a great therapeutic option. It can significantly alleviate symptoms and enhance the quality of life. As professionals, healthcare professionals, it's upon us to remain informed, engaged in research, and collaborate with patients to ensure optimal outcomes. So I'd like to thank you for all your attention during this talk. And I welcome any questions or discussions, thoughts that you might have. Go ahead, put those in on the comments area, and we're going to go ahead and bring in our experts. Well, the one expert, it's me. So welcome back. We're live again. Hopefully that was informative. Now, I did say this is a tips and tricks. So I utilize what's on the website, what the recommendation is from Allergan, but I'm going to go and tell you what we're actually doing in real life. A little background on the Botox and my involvement. I was actually involved in the original studies that were done to get the FDA approval for Botox. Myself and one of our doctors were on that team, and we're conducting studies in our office. I was involved in a lot of administration with him, but I was doing the pre and post-op urodynamics to kind of show how well this worked. And this has really been a game-changing drug. And it's one of the things that I really enjoy in this field is the things that are game changers. Now, experience makes a big difference. Now, of course, Botox has been around for quite a while. I can't even remember when I did the trials. It was a long time ago. But anyway, the big thing is that that's changed is, the 100 milligrams is the 100 units, is the recommended dose for the original treatment of overactive bladder. I could tell you that's not what we use anymore. It doesn't really work very well at the 100 units, and the 200 units is the better dose. We mix the 200 exactly as you saw the 100 with 10 cc's, so we get a higher strength per injection, and have had great results with that. Actually, the AUA has put out a paper supporting that. The NIH is supporting that dosage. So again, it's definitely what has changed is using a stronger dose. We have also experimented with the number of the delivery of it, the number of injection sites. So, as you saw earlier, that you want to inject 20 areas and kind of have those as specifically kind of broken out areas. The only area you're kind of avoiding is the trigone. Trigone is kind of more thicker tissue. It's harder to inject in that area, so you don't want to inject in the trigone. But we don't do 20 injections either anymore. So what we're doing now is 10 injections. And again, efficacy at 10 injections, so 1 cc per injection, is just as good as it was with the 20. Less discomfort, less side effects as far as bleeding goes, and no increase in side effects or decrease in efficacy. And actually, I was talking with I don't do the Botox anymore because I'm semi-retired and I haven't been involved with it. But I was talking to the doc in our office who does these, and I said, "Hey, has anything changed since our last time that we were doing them together?" He says, "Actually," I'm trying now to do it in just 5 injection sites. He's had a few patients he's done this with, and he says it seems to be working just as good as it did when we were doing the 20 or the 10. But he said the real key is to, if you can get the insurance companies to cover it, start with the 200 unit dose. Now everybody's going to do their own versions of this and have their own comfort levels. Again, we've been doing a lot of this, so we've been modifying the routine because we've had the experience. So Again, let's open this to questions. So you guys are my expert panel. Bear with me. I'm going to bring these up on screen so I can read them. Tabo, hey, welcome. Tabo's one of our newest viewers. I like that post Botox handout and have the patient stay for 30 minutes. Our clinic doesn't do a good with about that. So not quite doing that. When patient's done, it's goodbye and see you later. Yeah, we like to have them hang around. I got to tell you that I can't, outside of urinary retention, I can't say I've seen a severe side effect, but I'm sure it's happened to somebody out there. So again, keep that in mind. But yeah, the handout's huge. I think that's always, I'm a big give patients information to take home. I actually started the Euro Patient podcast as a way to distribute all this patient education that I produced throughout my career. So we do a little video talk. It's on at 10:30 for patients, and there's a handout for everything that I talk about. And Botox will be coming up as one of my instruction things. Raj, welcome to the show. Thanks. Yeah, 300 units of Botox. Again, there is all sorts of different mixtures. Are you using the 300 for overactive, Raj? I'd be curious about that, because I know we're pushing the dose higher. So when you're not getting the efficacy. Also, I'd be interested, anybody out there, how often you have to re-inject patients. The length of time. Typically, we see patients getting good results for a year, some patients, and most for 6 months. Now, you can't give it any sooner than 12 weeks, and there's a few that are. But, think about the difference in quality of life. You don't have to take a medication. You don't have to remember to take a medication, and you don't have side effects. You're not dealing with the dry mouth and the dementia or memory issues that you can get with some of these pills. So really, really big fan of that. All right, Susie, welcome to the show. Any tips on mixing the Botox? Botox is the simplest thing there is to mix. The one thing you don't want to do, and you're tempted to do it, is when you are injecting into or taking something out of a vial and mixing it, you always want to expel the air, or you want to, draw back. Add air to it so that you don't have a vacuum created. This is vacuum sealed. And just like you saw in that video, full syringe, just pop it in. You'll see the syringe put itself in because it's vacuum sealed. The other thing that I will say is that's a little different with the Botox is you look at it and you think you got gypped. There's nothing in there. And it's you can see it. It's like almost like a film on the bottom. It's so hard to see. It's just crystals. It really is, like they say. All right, Heather, welcome to the show. Our clinic doesn't do, maybe there's 3 Botox in the clinic anymore, or they don't do Botox in the clinic anymore, only in the OR. But it's important that patients know how to self-cath before Botox. Good point. We schedule nurse visits to provide this education. Absolutely. This is definitely our field of expertise. We want to be the ones that are teaching patients. And I think it's number one, if you're going to be doing Botox, I think that has to be stressed. Are you willing to do intermittent catheterization? Now, I have seen plenty of patients have urinary retention after this. So the being able to do self-cath, again, is going to be a big plus. You don't want to have them end up in an emergency room, having catheters placed, all this other issues that you have to worry then about infection. So, and most, it's going to wear off eventually, but most patients that have retention, it's short-lived. So maybe they're doing it for a few weeks, up to a month, but it's not like the whole 6 months they have to do intermittent catheterization. So, yeah, thanks for that comment, Heather, and great reminder. Susie Swain said, it's so hard to draw up after we put the 10 mLs. Oh, you mean, so then drawing it back into the syringe. So I don't know if you noticed in the video, the one thing that he showed was taking and unscrewing the hub and letting air enter in there so that you have equal pressure, and then you can back it out. I'm not a big fan of adding air to try to, because you don't want it to spray. I use a large bore needle. I like to use the 18 gauge needle to do this, and haven't had any issues with drawing it out. But again, if you let it normalize, so you may have a little bit better result in pulling it out. Raj was talking. So yeah, for spinal cord injury patients, definitely it's the higher dose for sure. Yeah, I haven't never used the 300 for the overactive bladder, but the 100 we don't hardly even use. The only I do have to say we do have the 100. We do use it. It's one of our insurance companies will not, until they fail the 100 units, will not okay it. So even though we've sent information showing the AUA support, the NIH support, they're like, nope, 100 units is the starting dose for them. All right. So I don't know if we have any other questions. Feel free to put those into the it's been a great discussion. Normally it's fun to have my experts, but again, people are busy, just like myself, except I make sure that I take my vacation time and still get on the show. All right. Heather said, who assists the doctor with injecting the Botox? RN, LPN, NP. In our office, RN. I think that makes a lot of sense. And I did mention, if you're doing this, really the best way to do it, doctor-nurse combo, and the having a video system. If you're trying to do this, because you could do it without, the doc can look and just say, okay, push. But as you saw in the beginning, you want to get the air out of the injection syringe. So when you can see it, you can see when it stops bubbling, so you're not putting too much to push out. Also, when you you can see when that needle is buried, when to push it. So it's just you got that visual assist that way. So it makes the most sense. Raj is putting that. Yeah, added in the comments who's helping out. That makes a lot of sense. I strongly support it being a nurse in the office. I do know that a lot of offices are now switching over to using medical assistants to help out with things. I mean, I can't say that a medical assistant who's trained and been helping the doctor can't do this. There's, since you're injecting with the physician, is really not a reason. But I think that there's a lot of training that goes into this, post-op instructions and things to the patient that I kind of like to have that nurse involved. Pre and post-op urodynamic study. Yep. Again, do you need a post? And I did post urodynamic studies for the actual study. Do you really need a post urodynamic study after giving Botox? It's a lot of help ahead of time, so you really know that the patient truly has overactive bladder and not something else going on. But post, I don't know that there's any reason that I would want to put somebody through a urodynamic study who says, hey, I'm great. I'm not getting up and urinating every, hour, every 2 hours. I've got control of my urine. My symptoms are so improved. What are you proving at this point that if there's nothing there? Don't do. I always say, excuse me, don't do a test for the sake of a test. If you're not going to act on the results, it's a wasted test. I kind of go through this with things like blood tests and etc. If you're going to get a PSA, but you say, well, I don't care what the number is, I'm not going to ever have a biopsy. Why get the PSA to start with? You've got to act on the test. And the same thing, why do a urodynamics test on somebody who's treated and running, everything is working fine, unless somebody's got a good comment for that. All right. Well, it's been a great show. You guys helped me out here. Audience sometimes is a little shy when you start the questions. That's where the experts help get things going. But you guys were great. Got those questions in right away. So that helped quite a bit. And if there's no other questions that I see pop up, I'm going to go ahead and switch over to a little plug for next week's show, which I will not be presenting on. So I get a week off for sure. Anyway, here's what's going to be up next week.
The unveiling of MRI-guided prostate biopsy secrets signifies a paradigm shift in prostate cancer management. It ushers in an era of personalized medicine and tailored interventions. Unlike traditional blind biopsies, MRI-guided techniques offer a comprehensive view of the prostate gland's architecture. This enables clinicians to target suspicious regions with unparalleled precision. MRI-guided prostate biopsy not only enhances diagnostic accuracy but also facilitates risk stratification, enabling clinicians to identify aggressive tumors early and devise tailored treatment strategies accordingly. Join us next Saturday at 9 a.m. Central Time at uronurse.com to learn more.
So yeah, I'm looking forward to that one. We've used MRI fusion, where you take the ultrasound and the MRI images and you fuse them together to do your biopsy. But this is doing a biopsy under MRI guidance. I'm really interested to see how they do that and find out more about urology myself. So join us next week to learn more about MRI guided prostate biopsy. Until then, hey, everybody, go out and enjoy this beautiful weather. Summer's here. And hey, by the way, I think Susie Swain had this comment in there. May the 4th be with you. Today's May 4th. I've got some great plans here in South Carolina. There's a distillery that's having like a fest. So they're going to have music and food. And of course, they'll have some, I'm sure, some bourbon and things like that. So we're going to go hit that pretty soon. And the rest of you is enjoy your time. And we'll see you all next week on Uronurse.